I know it's a big topic. So today my topic of presentation is careful prescribing of benzodiazepines during COVID-19 pandemic. As we are all aware, benzodiazepines, it's a class of medications that are used for anxiety as well as insomnia. They came around 1960s and they are actually one of the most commonly prescribed medications worldwide. To give you an example, we have medications like clonazepam, alprazolam. These are all benzodiazepine class of medications. Over years, there has been rising concern of risk of overdose-related deaths, addiction, and long-term cognitive concerns with benzodiazepines. So I'm here to present to let you think about before prescribing any benzodiazepines. There has been a staggering increase, as I mentioned, in the last couple of decades, especially in USA and all around the world as well. There was a study published in JAMA, which is a very renowned journal in USA, last 2019 actually, and it showed that the prescriptions increased from 3.8% to 7.8% of visits. That's almost double. And most of the prescriptions were actually started by primary care physicians or other providers in the community, because as you can understand.
Kad si ti mislio doći? Ja sam ti izvadila ključić, pa se ti možeš ušuljati ako hoćeš, kad god hoćeš.
I'm sorry, I think somebody is talking. I hope you can still hear me. So today I'm going to talk about the side effects, the main concerns that are going around. The number one concern is the addiction and overdose. And the second main concern is the cognitive side effects. The cognitive side effects, as we know, benzodiazepines, they allosterically modulate GABA A receptors. The inhibitory GABA A, it modulates cognition. The problem is we are trying to focus on the limbic system. That's where our anxiety, insomnia sits, but it also is present in cerebral cortex as well as cerebellum. So that's where the cognitive side effects come into picture. There was a study published it was a meta-analysis done by S. Crow that showed that there was a statistically significant negative impact for cognitive domains of working memory, processing speed, divided attention, as well as recent memory. There was another study that was done in Canada, and that actually showed twofold increase in the risk with more than 180 days of use. So that's why, benzodiazepines are okay for short-term use, 4 to 6 weeks, 8 weeks, but long-term use has been a problem. As we know, overdose deaths have really increased a lot in USA, especially. This is the most recent data we just came out a couple of days ago. 100,000 died from May 2020 to April 2021. And 64,000 were actually death related to fentanyl, which is an opioid. It's flooding USA streets right now. So the deaths have nearly doubled in 5 years. Here we can see how the spike is happening. And this is, 2020, this pandemic started, and we are seeing it's increasing. It was already increasing, and now it's getting worse, as we can see. Here we see this data shows that benzodiazepines, which is green, it's present in a lot of these overdose deaths. Of course, number one is the opioids, which includes methadone, fentanyl, other opioids, then stimulants are rising as well, but benzodiazepines are a pretty big chunk of that as well. Here you can see benzodiazepines, the number increasing, as you can see, steadily increasing along with opioids. This is the co-prescribing, and this data shows there's a lot of co-prescribing of benzodiazepines and opioids. Here you see the gray line with opioids and other CNS depressants along with benzodiazepines. So this has been going on already. So what FDA, which is Food and Drug Administration, as well as CDC mandated in 2016 was to be cautious about prescribing opioids and benzodiazepines together when possible. So now we are not able to prescribe both of them at the same time because insurance is not going to approve it. They will ask you the reason for prescribing both of them together, which is, I think it's a step in a good direction. Then along with that, we started having prescription drug monitoring program to kind of control this overdose, this abuse of the benzodiazepine and the opioids going on. I don't know how many people are aware of this program or not, but it's a really good electronic tool, which now it's in almost every state of USA and it's mandated. So if I have a patient, I'm prescribing any benzodiazepine, I'm supposed to go to the website of prescription drug monitoring program and look of all the prescriptions this patient got from any other doctors. So if this patient got benzodiazepine from another doctor 2 weeks ago, it will show me, it will tell me that, hey, be careful, this patient might be doctor shopping. So it's a really good tool, and it has been very helpful to kind of control this doctor shopping. So now this COVID-19 pandemic came along when we were already dealing with opioid epidemic, benzodiazepine prescriptions, overdose deaths. As of yesterday, we have 5.15 million deaths worldwide from this COVID-19 pandemic, 257 million cases. We know this COVID-19 pandemic has been stressful from the get-go, when the lockdowns, when restrictions were in place, there was social disconnect. And I've seen that a lot in my patients. This disconnect increased anxiety, depression in a lot of my patients. Along with that, the fear, the worry of death and catching infection. So, people who already struggle with OCD, now imagine them washing hands continuously because of the fear of getting sick. So we know this has increased. So COVID-19 pandemic could cause a mental health crisis. Studies have shown an increase in anxiety and depression in healthcare providers as well as in general population. I'm going to show you some studies and some statistics. This is from CDC. Here you can see 2019, 20, and 21, how it has increased. The purple line, it's 2020, it's not even 2021. So from 11% to 42.4 in anxiety or depressive symptoms, that's a big jump. And we don't know what's 2021 like, but that's from last year. Substance use, here we can see the substance use has jumped. Suicide attempts have jumped. We don't have a data on completed suicide, but it's speculated that it's probably going to increase. Depression, anxiety, as you see, it has definitely increased. This is from UK from 2019 to March 2020, jump of from 10 to 19%, and US 11 to 42%. And this was published in Nature. That's a really big number. Now we know mental health problems is actually a risk factor for severe COVID-19. Here it's a CDC criteria, and we can see patients with substance use disorders, neurological complications, smoking, that's all high risk for getting severe COVID-19 and getting hospitalized. So a lot of our patients meet the criteria for that. This was a study published recently, actually. It was a 6-month neurological and psychiatric outcomes in 236 survivors. So these were the patients who got COVID-19 and survived. So more than 200,000 patients. And they wanted to see what would be the neurological or psychiatric complications from patients who got COVID-19. I was really surprised to see that a third of patients, 33.62, had neurological or psychiatric complications after COVID-19. So they recovered, they came out of the hospital, but they had these problems. Out of these, 12.84 actually received their first psychiatric diagnosis after being discharged, like 6 months post-discharge. And this is so true. I'm seeing this in my clinic, new onset of anxiety, insomnia, it's happening. This was another paper that was published, and this is sleep problems. So this was a meta-analysis done after, with the COVID-19 pandemic and sleep problems. Here we can see 31% among healthcare professionals. And you can imagine with the pandemic, there has been a lot of stress on healthcare professionals. So this increased, but even in general population, 18% reported sleep problems. And here you see 57% among COVID-19 patients. And this is after being treated for COVID-19, being discharged, and 57% still had problems. So half of them were still struggling. Moving along, suicides we know have increased. So 35% increase in last decade noted in the United States. Now it's speculated that because of, all the increase in anxiety, depression, substance use, as well as unemployment, there has been a lot of unemployment with COVID-19. So these are all risk factors for suicides. So this is speculated that the suicides, we don't have a data yet, but it is speculated that it will increase. So what do we do? Where do we go from here? We know this is increasing. So what is the treatment? What can we do? Now, of course, we know about psychopharmacology, but is that the first line of treatment? Should we just do that, or what do we do? We have to be careful with all this intentional and accidental overdose and suicides with this pandemic. Can we teach our patients self-care strategies? Can we engage them in mindfulness? Can we teach them yoga, other exercises to help them with their coping skills? Can we help them with sleep? Can we help them be connected to friends and family in certain ways. Maybe not face-to-face, maybe other treatment modalities can be used. Can we teach them resilience? Resilience, as you know, it's a trait that shows how adaptable an individual is to stressful events. So people with high resilience can adapt and are at low risk for anxiety, insomnia with stress, whereas people with low resilience are at high risk. And maybe that's why there's difference that not 100% of the population is struggling with anxiety and insomnia. People with high resilience are not struggling, but people with low resilience are struggling. Now, what do we do about that? We know that resilience could be internal or external. Now, internal resilience is something that we are born with, so we cannot really change that. But external resilience could be achieved with the help of psychotherapy. Preaching this trait to people can help to develop healthy coping skills and could decrease the rates of anxiety and insomnia in our patient population. American College of Physicians, they released the guidelines for management of insomnia in 2016, and CBTI, cognitive behavioral therapy for insomnia, is actually the first treatment modality for insomnia. So if I see a patient and they're reporting insomnia, maybe I should think about this first before prescribing any Ambien or any other benzodiazepine because of the complications that are related with that. CBTI, it includes various techniques like sleep hygiene to regulate the circadian rhythm, matching sleep opportunity with sleep efficiency, restoring homeostatic regulation of sleep by sleep restriction, relaxation techniques, and stimulus control. There's whole training on CBTI, and it's the best treatment modality for insomnia. There have been several studies done. There was a systemic review done actually that compared medications with CBTI. And CBTI showed to be more effective in long-term as compared to medications and really no side effects. So this is something we should think before prescribing any benzodiazepine for insomnia. Same thing with anxiety, CBT for anxiety, it's very well used, very, very beneficial tool. Exposure and response prevention. A lot of people are developing more and more phobias of going out and being around people. So can we help them with exposure and response prevention? Relaxation techniques, can we teach our patients those? Trauma-focused therapy. I'm hearing more and more cases of domestic violence and trauma happening when people are confined in one environment. So can we work on that? Can we teach dialectical behavioral therapy for our patients who struggle with personality problems like borderline personality disorder? So these are definitely treatment modalities that we should think about before even starting any benzodiazepines. As we know, medical community is divided on the opinion of using benzodiazepines. Some of us really like it because of the quick fix. You just give one prescription, the anxiety is gone, you feel really good. But how long? It stays for a few hours and then actually you get rebound anxiety. And how long can you continue that? Because you have to learn how to cope with this anxiety. This pandemic is really not going anywhere. Yes, we are getting vaccinated. Yes, cases are going down, but we keep on getting newer variants. So we really have to teach resiliency and coping skills and not just medication management. Of course, medications are there for severe cases. We have to weigh the risk and benefit before prescribing. We have to use safer tools before going to the medications. Now we know SSRIs, serotonergic medications, and SNRIs are really preferred medications and not benzodiazepines for the new onset of any anxiety, depression. They can take a few weeks to kick in, so you can use short-term benzodiazepine during that time as needed. But at the same time, these are really the research-based, the best treatment modalities for long-term use for anxiety, depression, and insomnia. Of course, psychotherapy, trained specialists, psychotherapists are very, very essential in our treatment planning, and we should collaborate and make sure that patients are getting psychotherapy and not just medication. There is limitation. We don't have enough psychotherapists, so that really limits what we can do. So it's good to start, some treatment in your clinic. I provide CBTI, I provide some psychotherapy along with medication management in my office. So I think that was very, very helpful to do that. With this was